Aditya, ready? Okay. Good evening, everybody. We had 3 weeks back sessions with the eminent faculties for discussion, and today being Sunday, hopefully people will join us. And I welcome Professor Manoharan. I also welcome Professor Sunil Joshi, sir, from Nandi Medical College Research Center, Chikballapur. I welcome Robinson George from the also. He's set to join. And sir, both of you welcome, sir, very much for a senior faculty for discussion. I again welcome presenter Nilakant Gowda and Pooja from Nandi Medical College, Chikballapur. Both will present spelling, probably parotid spelling. Straight away, we'll go ahead with the discussion. I think Joshi sir and Manoharan sir. So PPT on. Yes, can probably all of you can see the PPT. Pooja, you are presenting the
yes, sir.
the PPT. No, start presenting.
Okay. Good evening, sir. Today we will be presenting swelling in the parotid region. A 50-year-old gentleman named Mr. Ramanullah, by occupation, belongs to the lower middle class, comes from Kaivara. Shall I start again, sir? 50-year-old gentleman named Mr. Ramanullah, farmer by occupation, belonging to the lower middle class, comes from Kaivara, was admitted on 1st April 2025 and was examined on the same day. He comes with a complaint of swelling near the right ear since 1 month and difficulty in opening the mouth since 1 month. Next slide. History of presenting illness. The patient was apparently normal 1 month back, and swelling was noticed by his family members on the right side of face, below, behind, and in front of the right ear lobule. The swelling was onset. It was initially about 2 centimeter in diameter and gradually progressed to the present size of 6 into 7 centimeter. There are no similar swellings on the left side of face or elsewhere on the body. The swelling is associated with pain only when he tries to open the mouth since 1 month. Pain was dull aching in nature of mild to moderate intensity and it's of non-radiating type. It's aggravated only while chewing and relieved by taking rest. Swelling is associated with difficulty in opening of the mouth. No history of changes over the swelling like redness, ulceration, fungation, discoloration or discharge. No history of trauma. No history of fever. No history of loss of body weight or appetite. The patient does not complain of swelling inside the cheek, difficulty in swallowing or bad breath. No history of dryness or discharge in the mouth. No history of deviation of angle of mouth or difficulty in closing of eyelids or facial asymmetry. No history of ear pain, headache, or seizure. Yes, sir. Yes, sir.
Double voice is coming. Overlapping.
Okay, sir.
Some audio.
But we can hear, sir. We can hear her clearly. Yes, continue.
Yes.
No history of dryness or discharge in mouth. No history of deviation of angle of mouth or difficulty in closing eyelids or facial asymmetry. No history of ear pain, headache, or seizures. No history of cough and difficulty in breathing. No history of palpitations and chest pain. No history of jaundice and abdominal distension. And there is no history of muscle aches and joint pain.
Next, please.
Past history. The patient is not a known case of hypertension, diabetes mellitus, tuberculosis, asthma, and epilepsy disorders. No history of similar complaints in the past, previous surgeries or hospitalization. Personal history. He has a mixed diet. Appetite is normal. Sleep is sound and adequate. Bowel bladder movements are regular. He's a chronic alcoholic since 20 years. and he's a chronic smoker too, 4 BDs per day, and he has the habit of tobacco chewing since 20 years. Next slide. Family history, no history of similar complaints in the family. Drug history, there is no history of drug allergy. Medication history, he's not taking any medications currently. Next slide. Summary after history. An elderly gentleman presented to the OPD with complaint of solitary swelling in right parotid region since 1 month, gradually progressive, associated with pain, aggravated with trying to open mouth. There is also difficulty in opening mouth, and he is a chronic smoker, tobacco chewer, and alcoholic for the past 20 years. So,
Okay, all right. Now you presented the history. Can we go back to the first slide, please, where your presenting complaints are there?
The first slide. Next.
First slide.
Okay.
Okay.
Uh,
Yeah.
sir,
The chief complaints are swelling in front of the ear, near the ear, 1 month, and difficulty in opening of the mouth since 1 month, isn't it?
yes, sir.
And what about the pain? You said pain in the history presenting illness.
So, pain is, yes, sir, pain in the presenting illness.
Did he not present with the pain as such?
No, sir. These are his chief complaints. But while we asked him about the swelling, he also mentioned pain while trying to open the mouth.
pain, if it is there, pain should come under chief complaint. That's what Joshi sir is asking you.
Yeah, yes, sir.
It's important put pain. Pain is important symptom, no? So whether to put it in the, whether better to put it in the chief complaint if there is pain. Maybe
Sir,
yes, sir.
the question is, they said that he did not present with the pain as such, and
Yes,
it came retro. When they inquired into the history, they got the history that there is pain. So should it be put as a presenting complaint or in the history presenting illness? That is the question they asked me when we were doing the rehearsal examination.
Yeah. If it is a clear cut pain, you can put it in the complaint. Otherwise, fair enough. I think, sir. Manoharan sir also will
All
like.
within.
So next slide. Okay, sir, Manoharan sir and Joshi sir.
Am I audible, sir?
You are audible, sir. Yeah.
All history is within 1 month only, sir. Only
Yes.
in the mouth.
Yes,
And
sir.
he said pain also. I think that also will add to the history.
So this history, patient has told all those things in front, below, behind. The patient might have told in the face, in front of.
Yes.
If you put it like that, that is your infection finding.
Yes, sir.
It is infection. Patient won't be bothered whether it is in front, below, behind. You don't know the significance of that. If you tell in front of the ear, in the face, right side, if you tell that one,
Sounds smart.
that means you think it is a rapidly growing swelling or a slowly growing swelling.
Sir, since he mentions that the swelling has been there for 1 month, since then it has been gradually progressive, sir.
That's what in a month. It has started 1 month back. You have written already.
Yes, sir.
He said it has become a 7 centimeter size now in a month. You consider this one as a slowly growing swelling or rapidly growing? Nilakant?
Rapidly growing one, sir.
Must be a rapid. So in a month it is. That's what Manoharan sir wanted to express. It is in a month it is. Are you sure that it's only of 1 month or earlier it was noticed?
No,
No,
sir.
sir.
1 month only.
1 month only. Okay.
Yes.
So suppose there is a long history of many years and suddenly it has increased in size. What is your interpretation? In case, not in this case, not in this patient, but suppose similar
So,
thing, long history was there, suddenly started increasing. So
no,
how will you account for that?
sir, it's probably malignant. So, rapid increase in size would suggest that it's malignancy.
But how will you consider long history earlier?
Um, Sir, if it was a long history, it could have been benign and then changed to malignant suddenly, sir.
Absolutely right.
Very
Perfect.
symptomatic. Swelling might be small and it has been lying without any symptoms. Now only you say the patient is having difficulty in opening the mouth and now only it is and plus the size is increasing since 1 month.
Why?
Possibility is probably the swelling was there. for 1 month, and the patient did not notice because it was asymptomatic.
Yes, sir.
Can we take it like that?
Yes, sir.
The patient says 1 month because they have noticed it because it has become increasing size and
Increase in
producing
size.
and plus making the difficulty.
Yes.
Possibly, otherwise, that's probably difficult.
Yeah. The difficulty in opening of the mouth may have pointed out to the swelling.
Yes, sir.
The swelling. So
That's what sir is trying to say.
yeah, do you think it is related to the swelling or separate entity? This is what Joshi sir is asking and given a clue actually. Do you think
It's related to the swelling, sir.
related to the swelling? Okay, so how exactly it is? We'll just find. We'll discuss while you are discussing about the present palpation. We'll say or impression. Okay, next slide.
Ideally, if there are two symptoms or two or three symptoms, they should try to correlate and try to put into one entity and then think of them as separate entities.
Separate entity. First thing always correlate and consider one.
Yes,
one
yes.
condition. Then eventually
Yes.
during analysis you may think of two conditions which is different entity. Maybe possible, but always initially you have to consider as a one entity. Okay. So welcome Divya. Divya is from Gujarat. She was my student. Divya joined us. Divya, welcome. You can
Good evening, sir.
begin.
Good evening, Sunil sir. Good evening,
Good
Manohar sir.
evening, good evening.
Continue, sir. Sir, this slide, sir.
Okay.
So what you meant by because difficulty in opening mouth with a swelling like this, sir. So which means what for you?
Sir, difficulty in opening mouth while chewing, sir. While chewing or while speaking, it's because of muscular involvement, or it could be due to the involvement of the temporomandibular joint, sir.
Okay, but the joint, you look at the swelling joint is rather
Yes, sir.
mostly
It's
it is the muscle involvement. Which
muscle involvement.
which muscle involvement causes like this?
Sir, it could pterygoids, sir, medial pterygoids, or the buccinator, sir.
Medial pterygoid. That is all. There are only four muscles:
Yes, sir.
temporalis, medial pterygoid, lateral pterygoid, masseter. So
Yes,
such a situation arises only most of the time, commonly by involvement of the medial pterygoid. Absolutely right, sir. Sir, anything is trauma? She said that. Why you are interested in the trauma?
Sir,
Trauma, history of trauma.
Sir, history of trauma is important because of trauma there can be hematoma, sir, hemorrhage inside the gland, or this could result in swelling, sir.
Fever? Why not fever?
So inflammatory changes, sir, could result in fever.
Parotitis.
Parotitis.
Parotid abscess causes trismus.
Sir?
Just asking whether parotid abscess causes trismus.
Yes, sir.
Yes, it causes commonly.
Yes, sir.
Okay, right. Okay. Right.
Usually always think of mandibular injury. Suppose there is an injury, probably patient has not noticed.
Mandibular
Only by injury, probably.
Sir and Manoharan sir, anything to add on? Anything to add on to or anything to ask? They have answered most of the things.
But palpitation, chest pain, and muscle aches and joint pains may not be mentioned.
Yeah, joint pain.
Rest of the things they are told very neatly.
Unless you say autoimmune disease, Sjogren syndrome.
No other symptoms.
Otherwise, relevant to this in a month duration. At UG level, it's okay, but PG level, it will be.
Other systems you want to mention, you can say no other symptoms.
Yeah, that's what. Okay, right. Sir, Joshi sir, Manoharan sir, anything to ask?
Sir, is there any change of the size of the swelling? Has the swelling been progressively increasing, or has there been an episode of remission and exacerbation? And if that is there, what does it suggest?
She said 2 centimeter to 7 centimeter in a month. It has increased drastically. That's what she has mentioned. I think somewhere she has mentioned.
Yes, sir. Yes, sir.
She has mentioned. Okay. We'll go to next slide, sir. Next slide.
Yes, sir. Yes, sir.
So, why similar complaints? Why you asked? Heart surgery, hospitalization.
Sir, recurrent parotid infections can also result in malignant conditions, sir, which can result in a swelling which could be probably malignant. So we're trying to rule out recurrent infections or any swellings related to swellings that have been presented in the past, so that will help us substantiate a diagnosis, sir.
You are not very clear about your expression, but actually, if a pleomorphic adenoma is operated earlier, if it is not clearly removed, then there are
Recurrence will be.
recurrent pleomorphic adenoma has got high chances of turning into carcinoma.
Carcinoma.
For reasons you should ask previous surgery in relevance to the parotid swelling as such. Okay. So diet, sleep, sound, everything you're told, chronic alcohol, anything to do with the smoking.
Yes, sir. Smoking is significantly important in Warthin's tumor, sir. Warthin's tumor is caused by, which is bilateral parotid swelling, is caused by chronic smoking, sir.
What is that? It is common in which patient, male or female?
Males, sir.
Is it usually which pole is which lobe is involved? Smoker. Okay. What is the specific about the Warthin's tumor? What is otherwise called?
Adenolymphoma.
Okay, absolutely. What is the specific about the Warthin's tumor?
Sir, it's a bilateral swelling, sir.
Okay.
And it is a benign condition, sir. It is benign.
Okay.
Bilateral.
Smoker benign, you are told.
Yes.
But how will you investigate? What is the specific investigation for that? Nilakant, you can also answer.
Sir, specifically it affects the lower pole of the superficial lobe, so that is a significant one.
Okay, that she has already told. So specific investigation. The technetium scanning is a very relevant.
Yes, sir. Technician 99.
That way smoking is very relevant. Sir, anything to add on to sir in this Joshi here?
Next slide.
So next slide. Right, family history. This I have been telling in the earlier presentations also. You have to detail the family history. Family tree is very, very important. I didn't correct that because I thought I will express properly. Family tree, 3 generation is important. How many parents and how many children patient? Have you asked how many children patient is having? How many siblings patient is having? How many siblings patient's parents are having?
No, sir. We didn't ask about his siblings, sir.
That's important. 3 generation family history is important.
Yes.
Thyroid,
Yes.
abdominal mass, colon, and sometimes here also. So family history in all long case, 3 generation family tree you to draw and your test press. And it will also give some economic backup also. So economic backup also you have to add on to that. And you tell family history. It is not sufficient if you know history of medical complaints in the family. Relevant detailed family history, 3 generations should be expressed. Always when you write a case sheet, especially is it clear, Pooja, Nilakanta?
Yes, sir.
Yes, sir. Yes, sir.
No drug allergies, history of notice. Okay, which drug causes which drug you are interested?
Sir, anticonvulsant, sir. Anticonvulsant.
Okay, might cause sometimes swelling. So alcohol, why it is important for parotid?
Sir, alcohol can dissolve it. Usually, I'm not really sure, sir.
Alcohol causes
Chronic liver disease.
Chronic liver disease, bilateral parotid enlargement is quite common, no?
There's
Yes.
a disease.
Fatty infiltration of the parotid in chronic liver disease, alcoholic patient. So if you see if a chronic alcoholic, if you observe them, they've got a bilateral parotid, very common. Be careful.
There are beautiful pictures in the textbooks which show what are the symptoms, what are the systems involved, and they draw a picture in chronic liver disease and mark out that parotid is involved, bilateral parotid enlargement.
It's very common.
So it's one of the chronic liver disease
disease.
symptoms. Yeah.
Alcohol is important.
As Sir said, DCLD and even rarely leprosy.
Yes, sir.
Leprosy also very rare.
Yes, sir. He's not taking any medication currently. Okay, next slide. So family history is important, remember.
Yes, sir.
Summary, you added complaint, swelling, gradual progressive pain. pain aggravated while trying to open the mouth, difficulty in opening the mouth. He's a chronic smoker, alcoholic chewer. All the things are addressed. Pain is mild, it's not severe. It is only while opening the mouth. You have given the reason why there is trismus also in this patient. Sir, will Joshi sir,
So the
anything
mouth,
to add?
how much of the mouth he was able to open 1 month ago, and how bad is it now? Whether he's able to take his food bolus, is he able to
Sir,
eat?
it has progressively gotten worse, sir, and he's not able to eat as well.
Before swelling appeared, no, that before swelling appeared, there was no trismus. Are you sure about that? Have you asked? Leading question and
Sir,
confirm.
yes, sir. As the swelling is before 1 month, he was fine, sir, and he's come to the hospital because of the difficulty, sir, in
Okay,
opening
that
the
means
mouth.
what? Already we have discussed. That means what?
Yes,
That means it is. So this trismus is related to this swelling.
swelling, sir.
Even though that is not that common, but it just happened in this patient. It is happened like that. Okay.
Yes.
So, sir, there is a Manohar, go to the exam.
Any difficulty in speech?
Yes, sir. Actually, even while trying to talk, he has difficulty in speech, sir.
Any difficulty in taste? Chewing and taste?
Difficulty
Chewing, I mean, difficulty in chewing and
chewing,
taste.
yes, sir.
Taste,
Chewing.
taste, any difference, any taste difference? Food
Taste differences is not there, sir.
Salivation is increased. Anything, Pooja?
No, sir. Not increased.
Have you asked specifically?
Yes, yes, sir.
No dryness of mouth you have mentioned.
Yes, sir.
Similarly, increased salivation also important. Okay.
Yes.
Sir, we'll go to the examination, Joshi sir. Next slide. Okay. Nilakanta.
Yes. Now the general physical examination, sir. The patient is conscious, cooperative, and well oriented to time, place, and the person, sir. And he is a moderately built and moderately nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, edema are noticed. In the vitals, the pulse has been recorded in sitting position in right radial artery pulse of about 76 beats per minute. So it is a regular rhythm, normal in volume and character. And there is no radial or radiofemoral delay. Vessel wall appears to be normal. And the blood pressure is about 132/80 mm of Hg, recorded in sitting position in right arm. Respiratory rate is about 14 cycles per minute, that abdominothoracic type. And the temperature is of about 98.6 degree Fahrenheit, recorded in normal thermometer in axillary regions. And the next slide. Then now the local region.
One second, hold on.
Yes.
Nilakanta, I agree with your general physical examination and other things, but do we have any differential diagnosis at the end of the history, based on the history?
Yes, sir.
We skipped that part, forgot about that point.
Yes, sir.
Wanted to know
Okay. Actually, we could have discussed provisional diagnosis on history.
yes.
Sir, based on
history.
the history, sir, and with respect to the anatomical location, we can think that it is a parotid enlargement, sir, parotid gland enlargement.
Okay.
Differential
And there
diagnosis.
is no fever and
Sir, it could be lymph node enlargement, sir. Lymph node enlargement, or it could also be a lipoma, sir.
Lipoma.
Yes, sir. Just by the history.
Soft tissue.
How lipoma causes trismus? Why lipoma causes so progressive, rapidly progressing? I'm
Sir,
asking, I'm not questioning your differential diagnosis.
Sir, lipoma of the parotid gland, sir. Thereby again causing the medial pterygoid involvement and causing trismus.
But lipoma causing trismus?
Can lipoma cause this? Yeah.
Intraglandular lipoma.
Intraglandular.
How we should go to infiltrate? So it's a lipoma is a benign tumor. No? It will not infiltrate, cause any functional instability that easily. That in short duration. There is this is a swelling which has caused a functional instability. We can't open the mouth.
Yes.
No. So then something else. Which lymph node you are thinking of?
Sir?
Which lymph node you are thinking of?
Sir, it's mostly it could be a parotid lymph node, sir. Superficial parotid lymph node.
Absolutely right. Okay. Which condition you are thinking of from the lymph node?
Sir, lymphoma, sir. Lymphoma.
Okay, okay. Which type of lymphoma you are?
Non-Hodgkin's, sir. Non-Hodgkin's.
But okay, I'm not denying your thinking absolutely. But why can't we secondaries in the parotid lymph node?
Yes, sir. It could be secondary, sir.
Suppose if you consider this is the lymph node, which one you'll put first, secondaries or lymphoma?
Secondaries first, sir.
Why?
Then, sir, because parotid secondaries are more common than lymphoma, sir. Parotid through as the duct lymph node sir, the lymph node spread is quite common than compared to lymphoma, sir.
Okay, that's only not that reason because if you look at the secondaries and lymphoma anywhere in the body, very late to infiltrate surrounding area. If you look in the neck, axilla, anywhere. Okay, this infiltration is a very typical or early feature of secondaries. Understood?
Okay.
So that is why we consider, if at all, if we consider it is the parotid lymph node, probably it is secondary because of very short duration.
Short duration.
And infiltration. Trismus is a feature of infiltration in this patient. It's very typical. Understood? But first and foremost, you should tell parotid. Then comes up with the lymph node. And I don't think lipoma is a tricky one. You should not consider and probably rule out. So, then any inflammatory condition do you think? Parotid chronic, parotid abscess, parotitis, organizer abscess, or any such things because trismus is very common in them.
Sir, it cannot be an abscess, sir, because it produces throbbing kind of pain, and he would have mentioned it in the chief complaints itself.
He will have a pain first.
Pain
Yes.
first, sir. After the swelling is observed, after
Then eventually may get organized, but eventually go for healing process. So at least before considering lipoma, you should consider organized parotid abscess may be a better differential diagnosis than lipoma. Considering lipoma will be little uncomfortable for us. Okay.
Yes.
So,
That can explain both the the mouth opening issues that he has. And can it be some tumor arise, soft tissue tumor arising from the muscles in that area?
Yes, sir. There is a possibility. There is a possibility.
which condition? Will it be sarcoma arising from the soft tissue? They are pushing the parotid outside. That's what sir want to ask you.
Yes, sir. It's a very short duration, sir, and it's been rapidly progressing. So it could be a sarcoma.
Joshi sir, we'll discuss again different things later, sir. Otherwise, every
Okay.
point. Okay, go
Sure,
ahead
sir,
with the
sure,
examination. That's absolute
Sure.
perfect. You should be able to give some differential diagnosis after the history. That's what Joshi sir want to express actually, which we forgot to discuss actually. Okay.
Right.
So,
Okay.
right.
sir, and with respect to that, he has a long history of tobacco chewing and smoking, sir. We can consider that there is a tumor may arising from the buccal mucosa, sir, which may be protruding outwards.
Absolutely right. That's what initially I thought. If there is ulcer inside, it might have come and involve the skin. That is also next possible thinking you have to do in this patient.
And
because
infiltrating the bones like mandible and maxilla.
absolutely, parotid tumor causing trismus is not common. So something inside might have come and presented like this has to be thought of. You're absolutely right. That may be the another person probably differential diagnosis than other things. Okay, you need to think it's not a simple entity to straight away tell it is parotid. That's what exactly which is important. Continue with the examination.
Yes, sir. With consent from the patient, sir, we done a local regional examination. The inspection part, sir. The inspection is done in a sitting position from front and behind and side view, sir. And there is a solitary horizontal ovoid swelling of approximately 16 to 7 centimeter vertical transverse directions in right side of the face, below, behind, and in front of the right ear lobule to angle of the mandible. So ear lobule is slightly elevated and external auditory canal appears to normal. So borders are ill-defined. The next slide. So the borders are ill-defined, sir, except the posterior border. The anterior border appears to be 6 centimeter from the tragus. Posterior border appears to be 2 centimeter in front of the mastoid process. Upper border appears to be 6 centimeter above the angle of the mandible, and lower border is about 1 centimeter above the angle of mandibles. Skin over the swelling appears to be normal. Surface of the swelling appears to be smooth. No dilated vessel, scars, and sinus are noticed over the swelling. No swelling on the left side of the face or on the other parts of the body. The next slide. Okay. On palpation, No local rise of temperature or tenderness. They all inspectory findings with respect to the size, shape, and extensions of the swelling are confirmed in palpation. Swelling is horizontally ovoid in shape of about 6 to 7 centimeter in the right parotid region. Anterior border is of about 6 centimeter from the tragus. Posterior border 2 centimeter in front of the mastoid process. Upper border 6 centimeter and the lower border 1 centimeter just above the angle of the mandible. Next slide. Surface is smooth and firm in consistency. Swelling is firm in consistency. Skin over the swelling is pinchable, sir, and fluctuation sign is negative. It is a non-compressible type of swelling. Restricted mobility in both horizontal and vertical directions. Swelling is not very prominent on clenching the teeth and putting the masseter muscle into contraction. And no pulsations felt over the swelling. No swelling in the left side of the face. Next, neck region and axillary regions of the both sides. Next slide. And oral cavity examination, sir. Mouth opening is restricted. Then nicotine stains are present. Tonsils and fossa cannot be appreciated or observed. And halitosis is present. So the lips are normal. Anglostomatitis is present. Tongue is at center. White patches over the tongue. And buccal mucosa there is a swelling in the buccal mucosa which is firm. Ovoid swelling is appreciated with bluish discoloration over the swelling with white patches. And palate is erythematous. That hard palate is very erythematous. And bidigital palpation, right and left parotid ducts are palpated, and it is normal. Next slide. The facial nerve examination. The forehead wrinkles are present. Eyelid closure is intact, and nasolabial fold is prominent. Angle of mouth is not deviated. Taste sensations in the anterior two-thirds of the tongue is intact. No facial asymmetry is noted. Next slide. And temporomandibular joint examination. Difficulty in opening the mouth and restricted mobility and pain on the right side. And neck examination, no cervical lymphadenopathy, no other swellings in the neck. And systemic examination, sir. Cardiovascular system, S1 and S2 sounds are heard and no murmurs are heard. Respiratory system, bilateral normal vesicular breaths are heard and they are normal. Central nervous system, no focal neurological deficit. And per abdomen examination, soft and non-tender and no hepatosplenomegaly is palpated. And a summary of the examination. On examination, we observed that there is a solitary ovoid swelling 6 to 7 centimeter in the right parotid region, which is firm and immobile. Restriction in mouth opening. Deep lobe of the right parotid gland is palpated without facial involvement, and pre-malignant lesions in the oral cavity are present.
So we'll go to the first slide. Inspection.
Yeah, good. So let's dissect into it and see what you have done in the inspection. Okay. You said how you examined the swelling, isn't it? The position and what weaves you saw in which way.
In a well-lightened area, sir, and with as in sitting position, we examined the person.
Now you have mentioned that there is a solitary horizontal ovoid swelling, and you've given some the location, and the dimensions. And only thing is, what I'm seeing is you have used ear lobule as your landmark.
Ear lobule is you are not mentioned about curtain sign. What is curtain sign?
Sir, curtain sign, sir. Sir, this the deep fascia, the deep fascia of the parotid, sir. It has been limited to the zygomatic bone, sir. So that the parotid gland is not movable above the zygomatic bone.
Okay,
that's so this is a curtain sign, sir.
Of course, I think palpation you have mentioned. I'm not sure. You said borders are
no, sir. This is
borders are indefined. We said.
Yes, sir. Border surface they are fusing with the surrounding structures, sir. They are not well ill-defined, sir.
Okay.
But the posterior border is appreciated, sir.
Okay.
Well appreciated.
Manoharan, sir.
All the borders are ill-defined?
No, sir, except the posterior borders.
Can we see that picture enlarged, please? Photograph.
Picture.
You have it separately?
Yeah, go back. Go back the photo. Yeah. You can see that. One more photo. You can go back. One more back. Yeah, you can see here. You can see back. Side view also there. Front view also there. Nilakanta. What is
Yes.
neck? There is a wrinkling. What it suggests? Anything? Is it a significance? Sternometer muscle is okay.
Sir,
Is
There is
very
sir, platysma sign, sir.
let
platysma sign. Okay, that is that looks like. Usually it is seen in the neck swelling, but probably what it suggests, what it suggests means what? If there is platysma sign in this swelling, probably it is extending into the
Next.
neck.
okay. Where is platysma or RSS from? You have got any idea?
Um,
Nilakanta or Puja?
Sir, exact landmark we don't know, sir, but
Okay, okay. It's absolutely. He's honest about it. I really appreciate. Platysma is a particular muscle. It
What is
starts
what is
carrying from the deltopetal fascia, not from the clavicle.
what
From
is
the
platysma? What
it
is
goes
platysma?
and goes added to the submental gland. What is the platysma significance? What is the use of platysma? Both sides it comes like this, you know. Both sides it
yes.
comes like this from here. From the deltopetal fascia, it goes upward like this. So use is it gives the counter to the neck. Second thing, it supports the neck veins. So they keep the neck vein patent, surface veins, superficial veins. So that
Subcutaneous.
it
One of
the
the subcutaneous muscles.
venous drainage. Okay. So that is platysma sign common in the neck swelling, especially secondaries. That means it is probably extending into the neck. That's the only thing you can interpret like that. She's absolutely right. It's a platysma sign. So, Joshi sir, you want to see anything in this their inspection? On
Yes,
your
yes. Now, the question, important question that we wanted to know: whenever you define the extent of the swelling, should can any soft tissue part be taken as a landmark, or is it always bony landmark? So that's a question to you as well, sir. Just for clarification. But the students wanted to know: can we take some soft tissue to define the extent of a swelling, or always use a bony swelling, bony landmark?
uh,
sir,
No, it
you
is not.
understood the question, Pooja? What the soft any soft landmarks you want to express? If not, you are
sir,
told body landmark. I think you are told. I think.
yes,
Yeah.
sir. But we were also taking the tragus as our landmark for the swelling, sir. So, is it okay to take tragus as our landmark, sir, for this particular swelling, or should we always take a bony landmark for our extent?
Yeah, ideally, body landmark here, Vegas has to be taken as a landmark, and angle of the bones also may be a useful point to express how far anterior border is. Okay. Sir, anything else you want add on to this here?
Am I
V
audible,
Manoharan
sir?
sir?
Am I audible, sir?
Yes, sir.
Yes,
You are audible, sir. Please, sir.
Can you comment upon the surface of the swelling, ma'am?
Nilakanta or
Yes,
Pooja,
yes, sir.
How is the
surface.
surface?
sir. Surface is
Surface.
smooth, sir.
The,
On inspection, the
On
surface
the
appears
it
to
is
be.
smooth.
you see the swelling, is it so smooth, like a globular swelling or not, something like that?
It's
They,
not
they should,
lobulated, sir. It's not bossulated or lobulated. It is just smooth, sir.
it is
One.
it is smooth. It's not baselated.
Okay.
So go back to the inspection. We'll go back to the inspection, sir. Okay. Next slide. This you are not finished, no, Nilakanta?
Finish it, sir.
Finish. Okay. Next slide.
Okay.
Okay. This is for discussion. No, go back. Sir, anything else to add here? Skin over swelling appears to be normal. Surface
Okay,
of
okay.
swelling appears to no. Smooth is head. No, that
What
will
particularly we are looking at? What particular thing you are looking at over the skin of the swelling as with relevance to this swelling? What exactly were you looking for? What do you expect, or what would you see?
Sir, any secondary changes, sir? Like ulceration or fungation or
Foundation.
or redness. Uh,
For inflammatory redness, we can see, sir.
First,
And
whether
for any sinus or
can
fistula from the
implement
parent.
skin is stretched or not.
Sinus and fistula, isn't it?
Yes, sir.
Especially when
minus
when you think the swelling is corrected.
means redness should have mentioned. Other side they mentioned okay. Swelling appears skin or swelling appears normal they mentioned. Surface smooth they mentioned. Next slide. So tragus she has mentioned 6 centimeter from the anterior border. Okay.
anterior
So
body.
we have measured
Anterior
anterior border usually. Okay. posterior about 2 centimeter, upper vertical from the lower part 1 from the angle of the mandible. But how far below from the zygomatic bone? And why you are not mentioning the curtain sign in palpation?
Sir, we see that the parotid gland, this swelling, sir. Sorry, the swelling, sir. It is completely restricted movement, sir.
Okay.
It is completely restricted in all directions, sir.
Okay,
So
where somewhere you have mentioned mobility is restricted.
Yes, sir. We have mentioned, sir, in the palpation.
Restricted mobility is not mobile, or some mobility is there?
Immobile.
It is immobile, sir. It is completely restricted.
Immobile. No, why you put it as restricted mobility? Restricted mobility is a very like a trishanku. It is so neither that side nor
Restricted is reduced or
altered.
altered.
It is fixed swelling.
It is
It's
an
immobile. You can immobile.
You are telling it is fixed swelling.
Yes, sir. It's a
Fixed
fixed.
to what? Fixed to what?
Sir, it's probably fixed. It's under the fascia, but
Anywhere by usual principle. Exceptions I'm not asking. When you say fixed, usually it should get fixed to what? When it is not mobile.
So fixed to might be fascia or the bone, underlying bone structures.
Musculus.
Get mobility unless you contract the fascia. No, muscle also. If you don't contract, mobility.
It could be fixed to the fascia or the muscle, sir. To say that it's
when you contract, that's why you check the masseter muscle contraction. Am I right?
yes, sir.
If you
Yes.
contract the muscle, mobility will be fixed, mobility will be restricted. But when you don't contract, mobility will be still some amount of mobility should be able to elicit. So probability is usual. By usually any swelling is totally fixed means what interpretation you will have? Any swelling, forget about this swelling, anywhere in the body. Means it is fixed to the what's the deepest structure?
The bone.
Bone.
The bone. So I am asking whether this swelling is fixed to the mandible or not. So have you checked? Have you done some clinical examination to confirm? To having said that this is fixed, not mobile. So next thing is whether this is fixed to the mandible or not. So have you checked? Have you done any clinical examination for that purpose? You understood?
Yes, sir. Yes, sir. Sir, we have checked if it's fixed to the masseter, sir, but we have not done any clinical examinations.
What clinical examination you will do to say that mandible is involved or not?
Sir, bidigital palpations.
Palpated the mandible in this patient.
Sir, actually, we haven't palpated.
You're on it, I appreciate, but you should have palpated the mandible for what? What for?
Sir, if it's fixed
to the mandible.
If there is mandibular involvement, sir. Thickness, if it's
thickening, one.
Yes, sir.
Second.
And if it's infiltrating the surroundings.
Thickening, tenderness.
Tenderness.
The two things mainly. Of course, sometimes they say fracture site. There is a different thing to elicit. Mainly thickening and tenderness, which is the hallmark of mandible involvement.
Yes, sir.
Okay. So that is the important thing I have observed when he presenting only mandible exams, very essential. Having said that, this is not mobile, that is more relevant here. Understood? You have to palpate the mandible. Okay.
Yes, sir.
Sir, Manoharan sir and Joshi sir, anything to add on to, anything to comment on their finding before going to the oral cavity examination?
Next slide, sir.
Okay, next slide.
Show us the slide, please. Show us the slide, please.
Okay, palpation. Not compressible fluctuation sign. Okay. Not non-compressible. Why you said non-compressible, sir? Any comment on that, sir? Non-compressibility. I think UG level they are allowed, but not because you said the firm and compressibility meaning
restricted mobility in both horizontal and vertical direction. Now here they have mentioned.
Yeah. What is the compressibility?
Sir, if it's to rule out vascular swelling, sir.
Okay, vascular and lymphatic swelling.
Lymphatic swelling.
Compressibility. What is the clinical meaning of compressibility?
Sir, if we try to push the swelling, it just comes back up, sir. There's no indentation. It doesn't fit.
If you press a swelling, it gets reduced. When you release, it comes back to its
normal size.
Original size. Word original size is very important.
It will displace the content. That's all. It will get refilled.
It will refilled. Actually, word sir has got proper word. it get refilled to its original size. There's a word, I think, absolutely right, sir. There's a word we should use, get refilled to its original size. That is compressibility, absolutely right, Richard, but where it is also we are told, but may not be much relevant here. Agreed. Swelling not very prominent, clenching the teeth, putting the masseter muscle, okay. Pulsation, felt in the swelling. Why pulsation?
Sir, again, for a vascular swelling,
Vasculars.
Vascular
vas-
swelling.
What vascular swelling there?
What vascular swelling you think of?
sir, hemangioma, sir, or lymphangioma.
Lymphangioma is the vascular malformation. It's only pulsatile. Vascular material is lymphangioma. What is research aneurysm? Have you seen any case?
Hmm.
Uh, sir,
It's common in this area, but doesn't look like this. Okay, this
sir,
is only
temporal, is it the
temporal
temporal?
region, the upper one, temporal region, not exactly in this area, but in the face and lateral part. Not exactly here. Don't worry
Yes,
about
sir.
it. Okay, but you should be able to express if it is pulsation, why you want to look for. Okay, swelling on the opposite side, neck region.
Sometimes pseudoaneurysms arising from superficial temporal artery to present with the swelling like this and superficial like
Yes, sir. Yes, sir. So why axillary region, neck region you want to examine?
Sir, if there is suppose if it is a metastasis, sir, rule out the metastasis. There is any lymph node involvement.
Why how axilla get involved? Neck region is okay.
Yes.
Period malignancy or wound malignancy can go to the neck lymph node. But why you want to examine axilla?
Sir, the metastasis, sir, it may also spread to the lung parenchyma, sir.
Oh, it will go to the lung. From the lung, it will go to the axilla.
No, sir. Again,
very uncommonly, you are thinking very uncommon situation. Of course, this patient itself is having some uncommon findings. That's important.
So,
simpler reason, level.
sir, to rule out the blood-borne
Diagnostic.
metastasis, we can.
Okay, metastasis. You have given Puja has given a differential diagnosis earlier. You found something, then I said no. Lymphoma is thought, no? You said
yes.
you thought lymphoma
So,
somewhere in the
so
description.
axillary examination in this case, you would do the general physical examination wherein you want to rule out the generalized lymphadenopathy.
Yeah,
Not in the local examination because axilla is not a draining area of the swelling that we have here. If it's a breast, if it's chest wall, you do axillary is fine.
But
Our regional drainage is into the cervical nodes, so we would want to
mainly
focus on
cervical node.
cervical nodes.
If
Yes.
you want to examine, it's accepted, but you should be able to give the
Supraclavicular
reason.
is fine sometimes.
You should be able to give the reason. When you tell, I'm thinking of lymphoma as a differential diagnosis, probably that's the reason I want to examine. Actually, you should be able to justify why you want to examine. You should justify why you want to do it. You should have a reason for that. That's the only thing. That's all about the clinical examination. Okay.
Yes.
So we'll go to the next slide, sir. Next slide. Back side. Local is next slide. That's all. Next slide. Oral cavity examination.
Yes, sir.
Yes.
So mouth opening.
In the buccal mucosa, they have patches.
Yes, sir.
Parenteris, erythema. So these are all intraorally have some one or two findings.
Yes, sir.
Yes.
So you could palpate the parotid duct, is it? Are you sure? Because you have written there. Because very difficult to palpate normal parotid duct, sir. Joshi, sir. Okay.
What I told him that you palpate, try to palpate the
How to
parotid
palpate?
gland and the deep lobe of some of your colleagues and friends. Then you will know what happens.
Okay, how to palpate?
Sir,
By
it is
this
again bidigital palpations.
palpation.
One inside, one outside, and feel
Yes,
it.
sir.
I feel.
So why you want to palpate actually? What is the reason behind?
Sir, again stones, sir, and we have to see any secretions, any purulent discharge being, which is being,
Where is the parotid duct opening?
Yes,
uh,
that's
sir,
the question.
Parotid duct in upper second molar region, sir, at the crown.
Okay. What is the duct called as?
Sorry, sir.
Usually, unless it is obstructed or expected, it is difficult to see and palpate.
Okay. What is the duct called as?
Tenson's duct.
Tenson's duct.
Tensor duct. Okay, I accept it. So that is the interesting thing here in this patient is a buccal mucosa. Some swelling is there. So how we'll correlate that is a little tricky for us also. Okay, so that's what, how to correlate. That is a little tricky situation in this patient clinically to
Yes.
correlate. So rapidly, trismus is at least explained, but what is that buccal mucosa swelling? Because you have seen what you felt. Have you felt it? Buccal mucosa swelling?
Sir, actually, it was a pre-malignant lesion, sir. When we have taken the pictures, it was like 3 days ago, sir. Then the swelling has appeared. Well, while we were examining the patient, we just found pre-malignant lesions over the buccal mucosa, sir.
Could you when after putting the finger inside the oral cavity over the swelling, and
Yes.
could you able to palpate outside and see whether there is any continuation of the palpatory finding from outside to inside, or could you feel the separate things? Sir is showing actually. Manoharan Sir is showing like this.
Yes, sir. Continuity, sir. It felt like continuity, sir.
So if it is only buccal mucosa, it could have been independently mobile. So it is not independently mobile. Are you sure?
It's not
Yes, sir.
independently moving.
Okay, so you should be able to see. That's what sir is showing actually, Manoharan sir. Put your
Yes, sir.
finger inside, outside, you palpate whether it's a continuity or not. And otherwise, elicit independent mobility of the swelling inside. So if it is probably not connected to this, probably you consider it as independent swelling. So you are telling it is connected to that. Now
Yes.
again is the very question whether the swelling arises from inside or gone outside. So that's how the debate Nishad Nilakant has told initially thought he had expressed that. Probably have something inside and gone out. That's also a possibility you have to think of. But only thing is rise of ear lobule is very typical of the parotid.
Parotid swelling.
Yes,
Clinically, we have
parotid
to
swelling.
consider the parotid unless fluid. Otherwise, it's a very important clinical finding. Very expressive. Ear lobule rise is very uncommon in other conditions. So that's the only fact here to this one. Sir, we'll go to next slide, sir.
Yes, sir.
Sure, sir.
Have you looked the ankylosing is there? Tongue movement have you checked?
Yes, sir.
Yes.
Yes, sir. Tongue movements are
It
present.
is present.
He could put the tongue out. It will tip of the tongue out.
Yes, sir. Yes, sir.
Okay. So there's no ankylosing.
No ankylosing.
Right. Facial nerve, you have told there is no facial nerve involvement, you are told. Okay.
Facial seems to be intact in the presentation. They look for all the 5 branches. What are the branches of facial nerve and where is it? How is it related to parotid gland?
Sir,
You know,
sir, facial
Facial
So
nerve
facial
branch
nerve-
is asking.
yes, sir. Facial nerve, it is divided into first branch within the glands. Parotid gland, it is divided into 2 main branches. There is the temporofacial and surfacial, sir. And then it has been again divided into 5 branches. The temporal branch, zygomatic branch, the buccal branch, and the mandibular branch and cervical branch.
Zygomatico-temporal and okay. Great. Okay. So it is not involved. And
Not at all, sir.
closing of the eyes is okay. Blowing of the cheek is okay. Whistling is okay. That is 3, very easy to check.
Yes, sir.
Yes, sir.
Blow, whistle. If you do these 3 things, somebody does these 3 things, straight away we can tell that facial nerve is intact. Very easy to check. Okay. Close the eye, blow, whistle. If patient is able to do that straight away, we can say that most of the time facial nerve is intact. Okay. So you are telling facial nerve is normal here. Okay. Next, neck lymph node you have mentioned. Next slide. This is also your told joint. You are told. Have you checked the joint movement? Difficulty in opening mouth, restricted movement. TM joint, pain.
So the the temporomandibular joint is not involved, sir. But the difficulty is in the anterior region and below the temporomandibular joint. But it's unlikely to be.
Can you feel the joint?
Sir,
Can you feel the joint?
sir,
Yes, yes.
opening the mouth, sir.
Can you feel the joint?
We can feel.
We can feel the joints.
Put your finger into the ear. You can feel ask the patient to move. You can feel the joint if you
Yes.
put the finger into the ear.
Yes.
Put the finger into the gloved finger into the patient's ear. Ask the patient to move the jaw. You'll be able to feel the joint, and if you're able to appreciate whether it is normal, restricted movement, or abnormal.
Yes, sir.
Always feeling is palpated by putting the finger into the ear. Okay. Okay. Next,
The difficulty is now because of the soft tissue involvement.
sir.
Joint is free, but
Yeah,
soft
this
tissue.
is so interpretation is it's not the joint involvement, it's the soft tissue
Soft
involvement.
tissue involved.
So you should be able to appreciate that. So you should, if that's why you should put your finger into the ear of the patient and ask the patient to move. You'll be able to feel the normal joint cartilage there. Okay, normal joint head you can feel. Okay, always on everybody can feel it. It's accessible joint. Okay, clinically. Okay, right. Next slide. So summary said we will go to the. There is what is tricky. Oral cavity there is something. Christmas is there. Swelling is outside. So go to the next slide. Sir, why you put most probably malignant? You got a doubt.
So short duration, sir, because of the short
Why
duration.
you put most probably malignant? You got a
Sir is asking why there is doubt.
tumor, no?
Why there is doubt?
Why I got some percentage of doubt?
Puja is still having reservations.
Unless you think of inflammatory condition, that you can put a differential diagnosis down. Inflammatory condition. Okay, what malignancy you are thinking of?
So the most common malignancy is mucoepidermoid, sir. So it could probably be mucoepidermoid carcinoma.
Okay, that is right actually. Why? How will you explain facial nerve not involved?
Sir, that's actually the differential. That's leading us to the differential diagnosis, sir.
No, not like that. Mucoepidermal carcinoma has got very less affinity for facial nerve.
Sir, the low grade.
Very late. Before involving the facial nerve, it involves the soft tissue. Okay. So facial nerve involvement is not a mandatory to diagnose mucoepidermal carcinoma. Remember, it does not have much affinity for facial nerve, unlike other malignancies. Look at the pleomorphic adenoma with the carcinoma, or look at the adenocystic carcinoma. All of them has got a high affinity for facial nerve, but not mucoepidermal carcinoma. Remember, is it a commonest malignant peritoneal tumor?
Malignant is
mucoepidermoid tumors.
Carcinoma. Okay, great. So, how will classify mucoepidermal carcinoma? Do you got any simple classification?
Yes, sir. Sir, low grade, intermediate, and high grade.
Is it low, intermediate, high grade?
Sir, as the facial nerve is not involved, I would like to put this in the low grade or the intermediate.
I said it won't have affinity. It is such a short duration. Soft tissue is involved so much. Rapidly progressing. Sir, Manoharan Sir has to tell. Joshi Sir. I think it should be
Definitely fits into this variant, isn't it? Variant of
at least intermediate and high grade, not low grade. You know, the low grade mucoepidermal lasts for many months, 6 months, 8 months, 1 year. Okay.
It's a very aggressive.
Which are deep lobe is involved or not? I'm just asking.
Sir,
we did bidigital examination, sir. Then there is chances of involvement of deep lobe of parotid, sir, because there is a.
You could see you could feel. They could difficult to see here. You could feel the push of the tonsil towards the opposite side, towards the midline.
Sir, not exactly the tonsil, sir, but we can feel there is a mass which are near to the tonsil of opposer, sir.
Okay.
Near to the anterior pillar, like that.
Okay. Deep lobe is involved.
Yes.
We'll accept it.
Considering the size of the tumor, also we should think about that.
Yes.
Size is too big. Naturally, the deep lobe may be involved. So that is one flow.
Yes, sir. So lymph node differential diagnosis we have already discussed actually. Joshi sir has discussed in the history actually. Lymph node preauricular lymph node. That is right. In the CH cheek buccal mucosa, is all. Why you have put CH cheek buccal mucosa?
Sir, because of the malignant lesion, we found leukoplakia, and erythematous palate, sir. So, there are white patches over the buccal mucosa, sir, which is leukoplakia, which could lead us to carcinoma of the cheek, sir.
Right. If there is an ulceration, bismuth swelling, still like initial expression, you have to think of oral malignancy involving the soft tissue coming out like that. Okay. So definitely like that, but think of in that angle.
What is the usual presentation of a CHE?
Sir, there is.
Is it a swelling or anything else?
Ulceration.
Ulceration.
Sir.
Most of the times it is ulceration.
Ulceration.
Yeah. Getting a swelling as a presentation of a cheek tumor is unusual in the absence of cheek, but yet, well, it can be a differential diagnosis. Yes.
Like Joshi sir told, no, ulceration, could you look for ulceration?
Sir, there was no ulcers, sir.
Okay, that's a important point. Joshi sir has expressed. You have to look for ulceration. If it is there, you may have to take as a relevance because it may be from that. Because you are still not sure whether it's really parotid or something else. Because there are so many things are not answered properly in this patient. Understood? Even
Yes.
though the first possibility is the plumor, parotid swelling, there's no debate. So many other things because of the additional findings, clinical findings, you need to look for. Like ulceration, look for makes your diagnosis different. So that's also important. Deep lobe, we have told, agreed. Mandibular tumor, you have put. What type of tumor you are thinking of? Jaw tumor. Which one is
Amylo,
tumor? No.
Sir,
ameloblastoma, I'm thinking about, or
or
osteosarcoma.
osteosarcoma of the man.
From the mandible, which is a common malignancy from the mandible.
Sir, ameloblastoma.
Ameloblastoma.
Ameloblastoma, adamantinoma, right?
Adamantinoma.
So how will differentiate osteoclastoma and adamantinoma?
Sir, in adamantinoma, the outer table is expanding, sir, and inner table is intact.
Intact.
But in osteoclastoma, the inner table is not intact, sir.
Absolutely perfect. Full mark to you. I don't debate on that. That is sufficient at PG level. Sir, I don't ask everyone that she knows. So whether they replace the mandibular tumor in this patient or not is a different. That's only debate, sir. Manoharan sir or Joshi sir?
Multi-stage they never said it is hard, sir.
Yes, sir. It is hard. It is hard. But putting as a different diagnosis cannot be because it be reasonably accepted because it is non-mobile. But the only thing is they have not examined the mandible.
They did very well, but mandibular part that they are not examined.
Yeah. So
Yes.
without palpating mandible, you are putting mandibular tumor. Yes, you palpate, then put it as a mandibular tumor. Definitely be accepted. And again, you know, osteoclastoma is a common, adamantinoma is a common. How to differentiate? You have expressed it sufficiently and efficiently. That's not a question. But if your only mistake is not examine the mandible. That is very, very important.
Can this ameloblastoma be so aggressive? And what is the usual age of presentation?
Sir, it's actually painful swelling, sir, but in gradually progressive. But it can get. But the size of the swelling is very large, sir. It can gradually progress into very large size, sir. It's a painless swelling, involved and can infiltrate the surrounding structures too.
Okay. All right. Let's proceed with what surprises we have in front of us. Next slide, please.
So, sir, we'll go to next slide. Investigations. Any discussion about the differential diagnosis, sir? Manoharan sir. I think these things are they expressed lymphoma. They given some reason for that. They said it presented because earlobe is right. This point you have to always tell Nilakant and Pooja.
Yes, sir.
First point is earlobe rise. And curtain sign you have to mention it is not done because of this reason. It is mentioned because it's the usual question asked in the clinical side.
Yes, sir.
Most of the time, when you get a case, it is usually mobile, unlike in this patient. And here, CHE, buccal mucosa, there is some reason to just your justification to put into that. Mandibular tumor, yes, accepted because it non-mobile is set, even though you are not examined the mandible. That's the default. Other things are okay. Lymphoma, you are thought of. Which lymph node you told? Not neck lymph node, it is a preauricular lymph node. Why platysma sign? We have given the reason because probably it is extending down into the neck. So that is the but the only thing is you said skin is pinchable. So whether it's a platysma, then skin won't be pinchable. So are you sure skin is pinchable all over the spelling?
Yes, sir. Skin was pinchable.
Have you checked everywhere? All over because it's better to check in different places in such situation. So some places may be adherent, some places it may not be adherent. So some sort of additional examination may be needed in such situation. Opposite side you have mentioned, axilla you have mentioned because thought of lymphoma. Abdomen for that reason only probably. Have you examined spine in such situation? Spine examination.
No, sir.
and it's a tricky case. We are not sure what exactly it is, pinpointing so many situations. So naturally, better to think of spine examination. Okay, so sir, anything clinically to add or give some points to them where they have gone wrong and I think most of the things they have presented, whatever they have not done, I have told, you can express your you before going to the investigation. Sir, Sunil Joshi sir, Manoharan sir.
Manoharan sir can answer because I think they have done fairly okay because I'm also biased because this is a case I have seen and I've been involved in. So,
Okay. So next slide, please.
Our SRB sir said, rightly said, skin pinch and you have to check throughout the tumor. Because such a big tumor, some areas it will be, of course, the central point it will be well stretched. So if you, unless you pinch everywhere and see, you cannot make out where is the attachment.
Yes, yes,
Soft tissue tumor in such a big size.
So examination entire swelling is
And
important.
they're pulling skin, you have to check everywhere, in all levels.
It's crucial, important, right?
What do you think is the plan of the swelling?
Sir, it was not prominent on clenching teeth, sir. So it is probably in the muscular involvement is there, sir. So it could be under the fascia and
Above the muscle involvement and above the muscle chances.
Remember, in such a big swelling, always definitely you must comment upon the plane of the swelling.
Okay. So before investigation, just want to mention one more thing. Have you felt the teeth, whether there is any loose teeth? Have you asked the history of
oral hygiene and other things?
Oral hygiene, loose teeth. That's important in such patient. It's not
Sir,
relevant, may not be relevant for parotid, but here you are clubbing oral cavity into the parotid. So history of loose teeth is very important when you think of oral malignancy,
yes.
So especially fine small ulcer may be missed. There is a mucosa close to the teeth. Patient may miss, we also miss. But so loose teeth may give you a direction towards that. So feeling loose teeth and history of recent loose teeth,
Falling of the
loose tooth is important in such a situation. Better to ask additional question and also while palpating, check that tender teeth, tender loose teeth, important finding, especially in this patient. Okay, may not be relevant for only parotid swelling, but here it is a club, not easy case. So investigation, you are told, is not going to the routine. Why ultrasound neck?
Sir,
Sir, to look for the involvement of the tissues, sir. What kind of the tissue may be involved?
Okay.
Whether it is a gland or muscle.
Guided FNAC is accepted, agreed. Okay. CCT, why MRI and CCT both?
sir, MRI to see any soft tissue involvement, sir, and CCT for bony infiltration, sir. Mostly for bony infiltration along with
And
some lymph node.
Okay. But when you do a PET CT, there is no need to see CT, probably. Sir, I don't know. Sir has to answer for that. Okay. Okay, agreed. MRI for soft tissues mainly. CT is the bone and the lymph nodes. Okay.
Lymph
So
node.
it is complementary to each other. It's not only MRI, you will do only CCT, you have to do. You decide on the independent individual case to case basis. Okay. If you are doing PET CT, CCT may not be necessary. Still, MRI may be useful if you are contemplating surgical intervention to these patients. Okay. So, what do you want to look for? Which soft tissues you are interested in this patient?
Mainly the parotid glands, sir.
Yeah, mainly soft tissue, mainly base of the skull. We are not sure about how far it is extending proximally, above and because base of skull is very close there. So if it is a base of the skull, then you need to have very clear idea, superior and distal extension. Okay, that's why MRI is quite useful. PET CT, not PET scan. PET CT is accepted because if you are putting some lesion, it is a T4 lesion, T3 to T4 lesion. So naturally, any T4 lesion warrants for the PET CT by principle. Okay, so accepted for both, agreed. So it is probably pleomorphic, malignant mucopolysaccharidosis carcinoma. What's the treatment? Next slide. You have written
Sir,
on.
total conservative or radical parodectomy, sir. Sir, as the
Wait. Put the bar there.
Hold on. What are the investigations that you have done and what it looks like? What are the investigation results?
Investigation
You done anything?
Sir,
Yes, sir. There are a seed.
No, I told report is probably mucopathy carcinoma, sir.
Yes. We want to know what is the report actually. What have they done anything? Any
Anything
investigation?
done in it is from your hospital? No, anything done?
yes, sir.
Yes, sir.
You
There is
done?
USG and CT also is done.
FNAC report is there.
Yes, sir.
Yes,
FNEC
sir.
report is also there.
Report has come as what?
Sir, USG was showing hypoechoic microcalcifications and vascularity in the parotid region, sir.
Deep
And
note is not. They may not
uh,
be able to make out in ultrasound, but still
yes, sir.
it is
Uh,
important to
it
see.
wasn't that clear, sir. So they asked us to do FNAC, and FNAC suggest report told us that it could be showed malignancy, sir. So this the report came as carcinoma ex pleomorphic adenoma, sir. Could be
Oh,
carcinoma.
no. We said there is no swelling before. No.
No swelling, sir, but the FNAC report said that, sir.
In that, no pleomorphic carcinoma, de novo carcinoma can occur.
Dino,
Carcinoma is a rare entity.
rare entity.
So, but very, very aggressive. Remember, de novo carcinomas are rare, but very, very aggressive. That is how it behaved, actually. You see the series of behavior, what has happened to the patient. So, de novo carcinoma is very aggressive than the carcinoma ex pleomorphic adenoma. Probably pathologists were not aware of the history. Otherwise, patient is small swelling might not have noticed, and it is ignored until it becomes this one small swelling. As far as the patient's history considered, it is a de novo pleomorphic carcinoma. Okay, it's rare but very aggressive. And otherwise, at your level, you should tell the mucoepidermal carcinoma. I think the
Yes.
most common facial nerve is not involved. And in carcinoma pleomorphic, de novo pleomorphic carcinoma, facial nerve is commonly involved. It is
Yes.
again clinical point which is against for that. Okay, so it's aggressive high grade mucopathy carcinoma. Probably should be the diagnosis. Of course, FNA is different. So post-operative radiotherapy. Why you want to do surgery directly?
Sir, we can perform preoperative radiotherapy too, sir, to reduce the size of the swelling and then continue with the surgery, sir.
Because it is, you said it is fixed to the bone.
Yes, sir.
Bone extending how far it is to the base of the skull. So get out to give neoadjuvant therapy initially, then reduce the size.
Neoadjuvant.
Contemplate for the surgery, no?
Yes,
And
sir.
there is no conservative surgery in this patient. Once you say malignancy, you have to do radical surgery. Sir, Manoharan Sir and Joshi Sir, you, sir.
So two things. One is nerve involvement and the tissue plates. These two things are very important in this case. So investigation means first MRI mainly for nerve involvement. Already the patient is having severe pain now. Audible.
Yes, sir. Yes, sir.
Then second thing is you rightly said you have such a huge tumor. It's difficult. You have to downstage the tumor. So give radiotherapy and whatever other amenities are there, multimodal therapy, try to reduce the swelling, then plan for
Surgery.
surgery. So you have to, because already there is pain. So nerve involvement and other things has to be there. Some sort of compromise, some nerve compromise will be there. So then you expect some residual defects. So all these things are multidisciplinary approaches. What has been done to this patient?
Not at the planned surgery.
No, sir. Actually he's been referred, sir. He's been referred to Kidwai, sir.
Correct. Because it's a multidisciplinary thing.
Right, at your level, neoadjuvant radiotherapy.
No. Let's talk about the CT. CT. What happened to the CT here?
CT,
Remember, such a huge setting, we have to rule out the lymph node involvement.
lymph node involvement.
Maybe you are clinically not able to do also because even lymph node is involved means that like ultrasound or CT may pick up for this thing. So we have to meticulously search for lymph nodes. Second thing is plane of the infiltration and the nerve involvement. So I think that gives the gist of this solution.
Suppose lymph nodes are involved in CT, what is your treatment after neoadjuvant therapy?
Sir, we would perform radical paratectomy.
Okay. Remove the lymph node. That is there.
Yes,
Okay, accepted. Okay, what are the complications of peritoneum? Just a minute, enumerate.
Sir, hemorrhage, sir.
Okay.
Hemorrhage, Infections, sir. Infections and flap necrosis, sir.
Okay. And phrase syndrome.
Phrase syndrome also.
Phrase syndrome.
Facial nerve palsy, important.
Facial nerve palsy.
Because if there is no facial nerve is there, periodontitis is so easy. It is simple excision like.
Yes,
That's
sir.
what every surgeon is worried. Okay, to save the facial nerve really requires trust. Okay, like if there is no recurrent nerve means periodontitis is very easy.
How do you identify the facial nerve? Any clues?
Sir,
Yes, sir. There are
Question? Anyone?
So redness, flushing, and sweating, sir, could indicate after a few months of the surgery, the patient could present with redness, sweating, and flushing. That could suggest phrase syndrome, sir. Because
You're talking about gustatory sweating.
yes, sir, gustatory sweating.
I am asking during surgery, how will you identify the patient?
Per operative during the surgery.
Puja, sir's question is on table. What are the landmarks for facial nerve identification? Trunk of the facial nerve identification.
Sorry,
sir, tragal point. There is a tragal point,
Okay.
and there is a
Sir, there is tympanomastoid suture, sir, which is 6 to 8 millimeter deep to tympanomastoid suture. We find the facial nerve, sir. We have styloid process, sir. Lateral aspect of the styloid process, we find the facial nerve.
Okay.
And also there is digastric posterior belly of the digastric. These are the landmarks, sir.
Okay.
Along with the groove of mastoid process and external auditory meatus, the facial nerve bisects this line, sir.
Okay, absolutely right. So all the things are theory question, different peritomy, superficial, total conservative, radical, and there are now parotid. It is classified now anatomically zones, zone 1, 2, 3, 4, 5. That newer classification is there for parotid, but it's not necessary at your level. Probably maybe after a few years it will come into the picture. Now this classification superficial and deep lobe is growing. It will go off eventually. Now currently parotid association has salivary gland association has classified parotid as a level 1, 2, 3, 4, 5. Not necessary for you. Eventually it will come up. There's a newer thing about the parotid. There are 5 levels in the parotid instead of lobes. Okay. Next slide. So sir, give a final verdict. Meantime, I'll put my slide. Joshi sir and Manoharan sir, they have presented very well, sir. I think excellent. They have presented. Initially, she had some.
Thank you, sir.
Thank you, sir. Thank you so much.
Sir,
Excellent.
Joshi sir, your students are good. They have presented well. You have
So
trained
very
them
nice
well.
of you.
That is
Thank you.
very
Thank you
good.
very much for giving us an opportunity. And
Thank you, sir. Sir, Manoharan sir, final comment about their thing and how salary land they should do. Meantime, I'll put on my slide.
So they did very well, sir. Both of them did very well.
So it's a common case, maybe long case, maybe short case.
Because this has got what the intraoral findings also, along with this thing.
Intraoral, they have mentioned, next they have mentioned, other things also mentioned.
On the UG level, they outdid very well, very full congrats to
Yes,
Thank you, sir.
they were presented very well.
Yes, sir.
Maybe motivation for other students to present. They have done well. Good. They have prepared well also. Sir, I will just go through my slides briefly in 5 minutes for student purpose. Next slide. All these are major, minor salivary glands. There are around 800 minor salivary glands. Some book mentioned 450. I found out the literature is around 800 to 1000. And remember all these which are not going to discuss. In submental salivary gland, marginal mandible lingual nerve, hypoglossal nerve is important. Saliva, serous, mucus, parotid serous, and submental salivary glands are mixed one. Some minor salivary glands are serous, some are mucus, some are mixed. There are so many minor salivary gland tumors. So tension duct, water duct names you should remember, where it attaches. Facial venous plane of plate you have to remember. It's important. This one empty question. Pest and illness, it is called a goose foot. It is called as how facial nerve comes like this. So that is also important by the fingers. You are told other things that are very exactly come from the tylomastid foramina. Next slide. So next slide. So history, all those things because salivation, excess salivation, he said it is not there. Other disorder, pain. Sir has discussed, Joshi sir has discussed pain. Manoharan sir discussed fever also. He told facial nerve palsy, if any duration, all the things we have discussed during presentation. I'm just putting into the in a Google, right? So features of facial is very important. Drooping history, drooling of saliva, inability to close eyes. They'll say tears in eye, asymmetry face, difficulty in opening in the mouth. So this is the history of facial nerve palsy. Next, different how they present with they look different parotid swellings. See that this is the last one is the submental salivary gland swelling. First two are the this one is the extending downward. Next slide. So these are the three just I'm mentioning. I'm not going through that. Swelling, site, onset, duration of pain, recent increase size, all the things we have discussed during our presentation. Just putting it in a nutshell actually. Pain is important when it is there. This is what Joshi sir has highlighted where to put in. This patient may not be in chief plan, but otherwise typically it is required like this. Recurrent swelling is about fever. I'm not going to detail it. You can always go through it. The start. Next slide. So other history also important. Trismus, you are told it's a present to the trismus. This patient very relevant. And excessive salivation, you told it is not there. I asked discharge, dry eyes, and other salivations. All the things I have mentioned actually. Past history, surgery, treatment. You have discussed personal history. Alcohol, you discussed diabetes, endocrine disorder, like the cirrhosis. You know the cirrhosis is
Yes, sir.
fatty inflammation of the this one. Cholestasis is different.
Yes, sir.
Cholestasis is the aseptic
Dilatation.
agitation of the ductules of the
Ductals of
and also bilateral.
glands.
Remember the differences between the cirrhosis and cholestasis. One
Yes,
is
sir.
metabolic, another is original. Okay. So next slide. So exams you are discussed. Next slide. So local examination, exam salivary gland, oral cavity also important. You have done that. Manoharan Sir has expressed. He said properly they have done. Cranial nerve again, facial nerve. You are told in the subbundal salivary gland. You have to look for hypocosal nerve. You have to look for lingual and other nerves, where whatever nerve comes, mainly hypocosal nerve, tongue to deviate towards the same side. Remember, tongue deviates towards the same side in hypocosal nerve palsy with the wasting of the tongue. Next slide. Next slide. Next back. So this is the examination. I'm not going to detail it, but spelling lies, all those things you are told in front, behind, all those things. Clenching of the teeth, you are told important. Size, shape, surface, nuclear, bossulated. Sir has told it's a bossulated pleomorphic adenoma. There's a specific word Sir has Manon Sir has used. I will look for bossulation because in pleomorphic adenoma usually it is bossulated. Depends, of course. And edgy, I mentioned we got a confusion about web-based edgy, ill-defined or well. Usually they are well-defined. Buffalo it's a very aggressive. That's it become ill-defined. And oral cavity, tension neck, head of the neck swelling, other things, surface consistency, fluctuation seen in parotid abscess and Warthin's tumor it is. So why you want to check fluctuation? If you are thinking it is a Warthin's tumor, it may be fluctuate. Abscess may be fluctuate. You should be able to give the reason. Mobility, fixity, and deeper plasticity. If it is not mobile, then you have to examine the mandible. We have told that. Palpation, tension, duct, water duct, you know, water ducts on the side of the frenulum with joints. Okay, deep low palpation vital, you know that. Next slide. So all these things are how to examine different earlobe rise, skin involvement, temperature, tenderness, skin pinchability, parotid duct examination, mobility. You said deep lobe examination. Yeah, last one. All the things are clearly. I just put it the photography for your understanding purpose. Next slide. So again, oral cavity examination, eye, facial nerve involvement, eye, closed eye to open, then clenching of the teeth and this buccinator checking the tone of the buccinator. After blowing, check the tone of the buccinator and try to open the closed eyes. Then, of course, lymph node examination in the submucosal gland, bilateral palpation, mandible exam. Lastly, it is seen there. No, that is the bilateral examination of the mandible. Okay, next, and of course, mandible. And again, how it looks like. This is the inflammatory submucosal gland. See that parotid swelling in the facial nerve palsy here. Deviates on the opposite side here. See that is the this parotid small swelling, but it's a malignant, presented with the facial nerve palsy. So this is again earlobe rise here. Here, inflammatory condition of the submucosal with the parotid Waters duct is involved. This is on-table facial nerve, pest censoriness, typical. So it's the laziest incision, Blair's incision or laziest incision for use, typically commonly used for the peritidectomy. So this is the incision MCQ question, laziest incision. Okay, modified Blair incision. Next slide. So exam facial nerve, I'm not going to detail it. It's called goose foot, pest censoriness, facial plate. All these things are important. How to examine orbiculars, oculi, occipital frowning, and tightening the eyelid. I have shown all the super, all these muscles. It's important. So when you check the test, which muscle is important? Orbicularis oculi, buccinator, orbicularis varis, levator angulae varis. Then platysma, difficult to check. I have written here. I have put where it originates from the delta petal fascia. It runs upward to the mandible, not from the clavicle. Remember. So always you get confused. It is from the clavicle. It's not from the clavicle. It runs over the clavicle from the delta petal fascia. That point you have to remember. Origin is from the delta petal fascia, not from the clavicle. So how to check which muscle is important? Okay. So that's why I put this slide. Next slide. So difficulty, all this, so how each finding where it, which causes which muscle weakness. So buccinator, orbicularis oculi, observantable is about frowning is difficult. Levator angulae, aries, platysma, mainly buccinator, you can't whistle because you can't open properly. Okay, clenching, of course. Again, upper motor lesion, lower motor lesion. Malignancy, the lower motor lesion, not upper motor lesion. Next slide. I ordered to jaw movement, feeling the joint, trismus, other pulsation you forgot, sir. Temporal artery, supratemporal artery pulsation you should check. It's very important. You are not mentioned that. That's very, very important in this patient. Okay. Then facial or taste, I have not taste your sensation. Have you checked taste? You mentioned that.
Yes, sir. Taste
That I have seen. For these things are mainly hypoglycemic necessary not mainly for the submerged cerebral gland. Lymph exam you have mentioned, other system you have mentioned. Spine you have to examine, especially think of lymphoma. Spine you have to examine. What you have forgotten is superficial temporal artery pulsation. It's very important in this patient because this is a fixed swelling you said. Whether it is palpable or not, it's very relevant. You forgot to mention. We also forgot to discuss and palpation. Next slide. So clinical diagnosis is important. All this it's like the same thing. I'm just putting it like that. Keep it in mind different. You have already done that. Evaluation, you are told that. Metastatic workup at CT. Next slide. And remember all that. Okay, remember this diagram where parotid, submandibular, sublingual gland comes. They always picturize this diagrams, very, very useful. Where exactly these three glands, major cerebral glands, anatomically located. This picture is very relevant to have an idea where exactly these glands are located. Next slide. And remember, surgical anatomy, glands, facial, oral cavity, both sides because bilateral important, cervical nodes, facial node, neoplasm details, of course, epithelial, non-epithelial, all those things. You can read my book. Salivary calculus, your discussed briefly, praise syndrome, facial node palsy. All these things are the common theory question. Remember, FNAC, CCT, MRI, PET CT, I forgot to mention. Lazy essence have shown need for radical dissection, neck dissection. You have told that. Complications you discussed, mainly radiotherapy. Remember, where parotid main adjuvant therapy is the radiotherapy, and of course, sometimes now they add on to the chemotherapy, oncologist. But main thing is you have to remember radiotherapy. Facial nerve reconstruction you have to remember, which greater nerve or other nerves you can take and do the reconstruction. These are the things you have to remember. Represent parotid swelling. It's very important. Right? This is the lazy sensation which is sutured. Next slide. So that's about briefly. It's very important question they will ask. Theory, lot of questions will come. MCQs they'll come. We should be able to remember these things. And this is my book, my website QR code. Please join my website. All students, I request because it's free. There is no payment for that. Daily lectures and MCQ. Now I'm putting daily MCQs. Please go through that. Put your answer, and in 12 hours I'll put the answer back. And also live sessions you can join to have a better knowledge about the surgery. Of course, I'm very, very thankful to Manoharan Sir and Joshi Sir and Robinson. Today he joined. Otherwise, last 1 year I've been joining. Manoharan Sir is always joining with me and giving a lot of support. Thank you very much, sir. You are always godfather to me. Joshi Sir, I'm thankful to you. I really.
It is very astounding to see this one talking.
What?
Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank you, sir. Final, this one, students have done well, sir. Really well.
Absolutely.
Not,
Proud to hear that. Proud to hear that from you, sir.
Thank you, sir. Thank you so much.
Sir, I would like to thank you for this opportunity to provide that you've provided us to be able to present our case. And sir, this is a wonderful learning experience. Sir. Thank you so much. Sir.
Thank you. Thank you. You did well. Both of you did well. And I request you all to join further sessions always. learn your comments. Always appreciable to make things better. And thank you, Sunil Joshi sir, for
Thank you very much, sir,
Thank you,
for
sir.
giving us an opportunity.
Manoharan sir, thank you for joining me. Thank you, everybody. I appreciate
Thank you.
you. Do well, both the students and everybody. And good luck. Take care of yourself. Good night, sir. Good night, Joshi sir, Manoharan sir, Pooja
Thank
and Nilakanta. Good
Good night,
night.
sir.
Divya, thank you. Divya,
We
your
hope
comments
you
you
get
can put.
university
Divya is my favorite student earlier.
Hope you will get the university
Uh,
medal this time in surgery. All the best.
Divya was my
thank
sorry.
you, sir.
He's a
Thank you.
practicing surgeon in Gujarat now. He was in Bangalore with me for many years. I forgot to ask him some comments. Divya, your comment, just tell me few minutes. Your voice is not there. Divya, voice?
Ah, yes, sir. Good evening, sir. Yeah, when you and sir all were telling, no need to comment. But by the way, sir, Pooja and Nilkant, they presented very well. So nice session, sir. Yes.
Absolutely. Thank you, Divya, for joining. Somehow I could have not make you to involved. Next time
Sure,
I'll
sir.
make
Sure.
involved in this one. And they presented well. Thank you, Pooja and Elakant both. Sir,
Thank
thank
you.
you very much. Good night. Take care of yourself.